Hello, it's a great privilege my talking to Dr.Venkat Ramakrishnan, a world-renowned plastic and breast reconstructive surgeon. And you can say something about yourself, where you work and what you do, because I'm not very sure of that.
I am Venkat Ramakrishnan. I'm a plastic surgeon. My main interest is breast reconstructive surgery. I work in England. I work in a what we call a regional plastic surgery center. It's a very big plastic surgery center just outside London. It's called St. Andrew's Centre for Plastic Surgery and Burns in Chelmsford. And we have different groups of plastic surgeons working together, and I perform the breast microsurgery. That is almost specialized in microsurgical reconstruction of the breast following cancer.
Where did you do your schooling? You are a Chennai lad,
Yes.
so that born brought up in
Yes.
Chennai.
Madras Christian College School in Chetpet.
Okay.
That's where I did my schooling. Then went to Loyola College.
Okay.
Those days was PUC.
Yeah. Right.
People now may not know what PUC is, but
Okay.
it was.
Actually, I belong to the last PUC batch.
All right.
78, 79. Loyola.
Loyola. And then went to Madras Medical College for my MBBS.
Okay. Now, how were you in school? Or you a topper, or one of the top in the school, or how was it?
I wish I could say I was a topper. I don't think I was the topper in school, but certainly maybe it used to be the first 4 or 5 ranks
Okay.
in my section. It was a very big school. We had 6 sections. And so I think I did well in some subjects, like physics was my strong one,
Okay.
where I got some medals and things. But otherwise I was, we can call it above average.
Okay. And why did you choose biology as your subject in pre-university?
Yeah, I've been asked this question in various other forums. About why did you choose plastic surgery or biology?
I'm not bringing your dad into the conversation as yet.
Yes. No, I just, those days, Dad tells you what to do.
Okay.
He guided me, and I don't think there was a very definite choice I made to take biology. He said, oh, you must become a doctor. You should, you should take biology, so you can go that route. And that's how I...
So he had an absolute control over your education?
Not control, but I didn't think of it as a control. I think you just... I think it's a generational thing. In those days, they just led you one way, and unless you're a very strong passion about other things, you just followed. So I felt like a bit of a goat being guided into that at that time.
So, but in Loyola, I think it's a very short 1 year.
1 year.
I mean, that goes flies off actually.
Yes.
And you've been working very hard to get good marks and all that.
Yes. Yeah, the pre-university is a tough one. So now you need to prove your mettle because you don't know what to do next if you don't make it.
Okay.
And you have to get the right scores. I remember it was something like you need to get an aggregate on 3 subjects. Physics, chemistry and biology.
That's right.
And there was a number.
Yeah.
And you have to have more than that number to be considered for medical school.
Yeah.
And it was tough times.
So that is an interview system to get into medicine.
Yes, interview system.
There was no entrance that time.
No entrance exam.
So did you try, say, Christian Middle College or Armed Forces Middle College, or your plan was just to continue your education in Chennai?
Yes, it was to continue in Chennai. My plan A was to get into MMC medicine, and we were the emergency batch.
Okay.
That time it was suddenly everything was stricter and much more controlled, and I think that was the first time they brought this kind of selection as well. Aggregate marks, and then you need to have a cut-off before you can qualify for an interview. And I think it was Professor Sarachandra.
Okay.
He was the person who was leading the interview panel
Okay.
those days. And yes, With regards to how you go into medical school, and if you can't get into it, you always had a plan B. My plan B was BSc in Loyola. So I had that seat as well. Zoology. BSc zoology. I had that, and this is the plan A. So.
But if you remember, I don't know whether Father Kuriakos was the principal. I think most of BSc zoology students quit the day they get MBBS. I think this is the second choice.
Yes.
And then as a standby. And one fine day you'll see all of them go to medicine and BSc zoo becomes empty.
Yes.
And Dr. Sarchandra was the professor of surgery.
Or he was a professor of surgery, and he was a dean as well at the time.
Okay.
And he was in the selection, Dr. Arumugam, he was a pathologist.
Okay, okay.
And Dr. Sarachandra, I remember them sitting across the table, interviewing.
Okay, what did they ask?
I don't remember, it was a blur. You just go show up, you're so nervous.
Right. But the marks matter.
Marks matter.
Marks matter. Yeah. What are the memorable things during MBBS? In other words, who inspired you during your earlier years in the initial subjects, non-clinical, and subsequently, how did you get into surgery?
Yeah, I think there are two individuals that come to my mind. One is a gentleman called Dr. Cooper. And Dr. Cooper was an anatomist.
Okay.
And he ran
the... Britain?
No, he's... I think he was Anglo-Indian.
Anglo-Indian.
And he was professor of anatomy in MMC for a very, very long time. And Dr. Cooper ran that Red Fort, the Red Anatomy building.
Right.
And he was a fabulous communicator. And his class, he used to start one end of the board, big blackboard. And the whole chapter he'll write with the different colored chalk and embryology and things. It is just like a textbook at the end of it. Unluckily, we didn't have the mobile phones. We could have taken a photograph that would have been made a book.
Right. Yeah.
But he was an inspirational person with regards to learning anatomy and dissection. He made it interesting because it is quite a difficult thing. You are exposed to formalized bodies, and you're spending a year and a half in anatomy labs those days, cutting and things, and yes, it could become very boring. But I think that is where my surgical sort of, he would have been the trigger for my enthusiasm to go to surgery, I think, because he delivered it so well. Then the second person is Sarachandra, because as a MBBS student, clinical years, you go to listen to professor of surgery in their rounds and things like that. And he was another important person.
So, by the time you're finishing MBBS, you made up your mind that surgery will be your career.
Yes. It was,
now, at this juncture, I should introduce Dr. Venkat as the son of the legendary Professor R. Venkatasamy, the father of hand, plastic and reconstructive surgery in southern India. And was he working in MMC?
No, he was, I think he studied, I know for sure he studied in MMC during his time as MBBS. Then all his time was spent in Stanley.
Okay.
His professional life, where he was a employed surgeon, it was all in Stanley.
Okay. Where did you do your general surgery?
In Professor Sarachandra's unit.
Okay.
I was so keen to work with him.
So there was an entrance between MBBS and MS, or once again the marks?
Marks.
What is the?
It was marks and the interview, I think. I don't remember an interview, going for an interview for general surgery, but I think it was mark and interview, very similar to the MBBS.
See, I have seen Dr. Sarachandra, because when I was a postgraduate, he was taking clinics in KJ Hospital. Every Monday he used to take it. But actually a lot of the present generation do not know about Dr. Sarachandra. They used to say that he's a walking encyclopedia. What is so special about him?
I think his knowledge, and more than anything, his interest in people. And I think I've seen even at this level, this stage of my career, you come across some legends in surgery, and you or medicine, I think the strength they show is the interest in people. May it be a patient, may it be the junior most resident, may it be the senior colleague of theirs. If there is something they say, they listen to it, and they try to explain. I think that was a big quality he had. He used to, you can ask him anything and then he will go on. I think I remember him once in this rounds, he was talking about something, and he started talking about the Parameswaran, and then he said Warren, and then the Warren pump, and then he went on to talk about some heat pump and heat sink, and he'll just go on a tangent, but he'll make it all interesting from one to another. So it's not only surgery you learnt a lot of other things.
And how was he as a unit chief, and how was he to his postgraduates? How was the training during those days? Because he's too big a person to concentrate on a junior most MS trainee.
Yeah, I think I was at the cusp of his retirement. I was he left about after my first 2 years of MS, and then Dr. Umapathi's unit I went to. But the first 2 years, I suppose you go and see the boss and assist him for big cases. The rest of it, interaction is with assistants.
Okay. Now, a lot of postgraduates doing MS general surgery, towards the end of MS, they won't have made up their mind as to which way to go. Because nowadays, the choice, there's no actually choice, it's come by chance to do all the exams, whatever entrance exams you write. You made up your mind that you'll be a plastic surgeon?
I think that jump from general surgery to plastic surgery was, I think, was inspired by my father, that bit. Although at the time of medicine and things, I just went on to do it. I think I looked at my dad doing what he was doing. And even those days, I think the bit that inspired was the microsurgery, microscope. For some reason, it's a gadget, so possibly it's just a interest in a gadget.
Okay. So microscopy has just come.
Just come in.
Okay.
They were just starting to do microvascular work and loop magnification, wearing fairly big loops to suture small vessels, small nerves, not vessels. Vessels came later.
So how did it go from MS general surgery? Where did you go and where did you specialize?
So I finished my MS general surgery, and at that time my dad did say you should go abroad to open your view of what is happening, because I was just getting MBBS in the same place, MS in the same place, and then the option was either I do MCH in plastic surgery in MMC or Stanley. And one thing I didn't want to do was to go to Stanley. Because of the obvious reasons. It is very difficult to work under your father, and there are lots of good and bad, but of course it's an irksome thing, I felt. So that is why.
But why didn't you do MCH in MMC?
Purely because it was the same institution, already invested 8 years, 9 years. Then,
so you believe that people should change institutions?
100%.
MBBS, MS, MCH should not be ideally should not be in the same institution.
So. And today's day and age, I think it should not be even in the same city. Because I think there are so many regional variations and small nuances we pick up when we travel. And we get set in our ways. As I think surgeons, we are the most obstinate people to change course. Once something works in our hands, we'll just keep doing that. And if you are in one place, the cross-pollination doesn't happen.
A lot of youngsters keep asking this question as to where should I choose my center of training, advanced training. I worked under Professor Samran Nandi, a GI surgeon, a world-renowned GI surgeon in the All Indian Institute of Medical Sciences. He used to give certain guidelines, and one of them he used to say is that you should try study or work in a place where you're going to live and die. You have to decide on a place that this is where I'm going to live forever, and that's where you have to center around. Because the networking, everything happens that way. And suppose if somebody studies in some far off place in the country, whatever contacts there will not be of a great help subsequently. I mean, that may not be really right. As a student, I think, as you say, cross-pollination is an interesting thing. But in India, again, now with the advent of these NEET exams, people are going all over. But there's one disadvantage that's seen is the language. Somebody who knows no Hindi goes to a center where is, what is your comment on that?
Yeah, the first point you mentioned about be in one place to get that street cred and utilize it to promote yourself and things like that. I think it used to be true in a generation maybe one step before my time, much before your time. I think today, this is a discussion that happens in the UK as well. People train in one region and then they stay there, they get the consultancy and so on for the same reason. But I think it does breed complacency. It doesn't challenge you because every time you change, I mean, I've studied here, MS, then I went to Australia and for doing my post-graduation, and I had to prove myself. I was nobody there, and from day one, but if I was in MMC, I was already and I wouldn't have to have the challenge. And the second point is, this day and age, I think the referral pattern, certainly in the UK, it used to be the general practitioners have to know you and they used to refer patients to you. So you keep in their good books, give them the good service, then they send patients. That has been disrupted completely in the last 10, 15 years because of the net, the social media and the internet, the knowledge people seek. If they want something, they want this specialized neurosurgeon who's specialized on the left side of the brain and that particular tumor, they find him, they seek him out. So I don't think people, so that has disrupted the whole, networking theory.
Right. So you believe that people should move from place to place, and
100%.
Ideally they should have undergraduation in one place, postgraduation in another place, and specialization at another place. Why did you choose Australia? Because I thought Australia is for pediatric cardiac surgery. Was it a center for plastic surgery too at that point of time?
Yes. Australians at that time were pioneers in microsurgery.
Okay.
There was a chap called Bernard O'Brien in St. Vincent Centre in Melbourne. He was the guru of microsurgery. He spent all his time manufacturing sutures, needles, equipment for enabling us, because at that time there was only macro instruments. So it was a very new concept. And also the first free tissue transfer where they took a groin flap and put it for a hand defect was done, the thing called free flap. The whole word was coined by a chap called Ian Taylor in Melbourne.
Okay.
So it was the mecca for plastic surgery those days, microsurgery those days.
Okay.
So that was the reason.
What made you getting interested in microsurgery?
That's my dad.
Okay. Yeah. He pioneered microsurgery in India.
In India. At that time, they were already doing this toe transfers and things. They had evolved by the time I reached that stage, and they were doing that. So that inspired me to.
How long were you in Australia, and what did you learn there?
I did all my plastic surgical training there. I was there for 4.5 years. So they, again, in Australia, the rotation. You cannot do more than, when you're a postgraduate, you can only do 1 year in one hospital or one plastic surgery unit. So you need to do 4.5 years to qualify for the exam. You have to find 5 different units for that, of which 1 year should be abroad, outside Australia.
Oh, okay.
For you to, you can do 3 years in one unit, but they'll count only 1 year for allowing you to the exam. So it is that underpins what I said earlier, because wanted you to mix with many other consultants, because you work with different bosses and their nuances, their quirks, why they do things. There's always two sides to the coin. So you learn that. So that's what I did, 4.5 years.
And you think that is a very good idea of rotating? Because in India, if you see Indian degrees, it will be in one institution. For that matter, in general surgery, for instance, one unit. You can't shift from one unit to another unit. By this principle, I don't know, was put to use in our system here. Here, if you really see, even super specialty degrees are done in one single unit, one single institution. Is it the same in the UK as well, when you have trained in the super specialty?
Yes, in UK it was. Now they've gone Indian way now. They are giving 4 years in one unit. If the unit has ticks the boxes, like if plastic surgery, for example, if you need to be in one unit for 4 years, they have to provide cleft lip and palate, hand, breast reconstruction, head and neck cancer, craniofacial. So if they have it, then they can rotate in the same unit. I suppose then if the unit has it, then they'll have groups of consultants doing each work. So it is almost like going to different units in one place. But otherwise, certainly if somebody works in Stanley, let's say, they have a big hand bias in plastic surgery when they come from MCH. Somebody works in MMC, they'll have more facial plastic surgery bias. So that kind of thing will be nullified. So that is a logic. But yeah, I firmly believe that people should move around, and it challenges the training. When you go and you meet a new boss from day one, you are on tenterhooks. You need to impress him.
No, but again, if it's 1 year in different units, you all start from scratch in a new unit. Does your seniority, your ability, does it matter in the new unit? Do they give respect for that?
I must correct myself. When you go to super specialty, for example, you want to learn liver, then you do 2 years fellowship in one place. That is where I believe that kind of thing, like microsurgical fellowship. You spend 2 years in one place. But by this time, your basics are well established, and you have lots of different inputs from the foundation, because you have a very good boss, you might learn a lot. If you are in a unit where there is not a good boss, that's it. The 3 years, you don't do much at all. So that is a vagary of the system here.
What are the peculiar things, or what are the special things in Australia that have influenced your career, which you still practice, which is not seen in the rest of the world, if you really look at surgical training in Australia?
One big difference between Australia and England, I compare both, because you join plastic surgical training, which is 4.5 years, and as I said, you have a formula you need to do. But from day one, you are gearing for the exam. So every 2 or 3 weeks, there will be a journal club or something you need to present, and they will grill you because you will be the junior most trainee there, and you will be being prepared for the exam. They will talk to you as if you are going for the exam. So what it allows me to do is to build up a big bank of factual information, the factual knowledge, although my skills were not up to the mark at that time. But in England and places, they only recently they've started the exit exam and focusing on the exit exam from the early training. Otherwise, you sort of go through 4 or 5 years just doing registrar jobs, and then the last year you buy all the books and start reading for the exam. So you've done many things without the factual knowledge to assist you. So that is a good thing about the system there, because it was every few months there will be a mock exam and so on. So that made me sit up and read from day one. That's one big thing. Another thing about the Australian system is Aussies are, as you know from the cricket as well, they are sort of roll up the sleeve and do guys. They don't pussyfoot around things. You say, can you do it? Yes, then do it. That's it. It's not sort of I'll hold a skin who can look at you and say you need to be confident to perform. So that kind of attitude, especially for a surgeon. I think that's a very important attitude.
Then, is it true that people who go to Australia will finish off their training and they go back to their own country? People don't settle in Australia? Is it that?
It used to be like that. I think now there are people going in, I think they need more surgeons. But at that time, it was an understanding that I finish my training and I go out. It was not a written thing or any contract, but it was, I think they did select me with that understanding. And I was not told, I think it was understood.
Okay, okay. And were you planning to return back to India?
Yes, I was planning to return back to India.
Then why did you go to England?
No, I came back to India.
Okay.
I came back to India and I was working in the private sector. This was between 91 and 95. At the time my father had retired and he was working in Wellington Hospital. And I started at Muller Hospital and I went and assisted him at Wellington Hospital. And he used to come and do some work at Muller. So it was a kind of a mentorship under my father. I was doing things at the time for a 4-year period.
Okay. And then why did you, because if you see Chennai, for instance, most sons who are of eminent personalities stepped into their shoes and took over their work in due course of time. But why didn't you do that?
I don't know. I think at the time I was rebelling, I think. I thought it was like this. If I got something or I did something, I secured something, I got admitting rights and something, it was always, oh, that he's doing it because it's father.
Okay.
If you do something good, so it felt like I was under the shadow and I want to prove to myself that I can. And I think that's what it was, I think.
Then where did you go to England and why?
Yeah, at the time, there's a gentleman called Brian Summerlad. I worked with him in England for 1 year. During my time in Australia, I had to go 1 year outside to do one of my years. So I went and worked in the St. Andrews Centre for Plastic Surgery and Burns under Mr. Summerlad. He's a cleft lip and palate surgeon. He's a world-renowned surgeon. And he was my sort of inspiration there. And he had visited India. And he saw me. And in fact, he came for a meeting. And I think that was the time MGR died as well. And he was stuck here for a
87.
Yes, 80s. All right, maybe I'm confused. Maybe it's a bit later.
Okay.
This was in 94.
Okay.
And it was another visit of his. And he saw me and I was saying sort of, look, he asked me how I was. I said, look, this is my problem. I'm doing things, but then, and he said, why don't you come over? I'll make arrangements. So he's the person who did everything and took me there.
Okay, okay. Dad was for or against?
Oh, he was always supportive. He always felt that I should go and do things and flourish on my own 2 feet. And he was, although he would support me in whatever way he can, he always felt that I should do it myself.
So the unit you went to specialized in what?
It was a general plastic unit.
Okay, okay.
Yeah. Those days, this is 95, most units did everything.
Were they doing microsurgery?
Yes. That microsurgery has become part of plastic surgery by then, but small volumes. Mm-hmm. Small volumes. In fact, when I joined them, that St. Andrews Centre, they had done something like 27 free flaps the year before.
Okay.
That's head and neck and leg trauma and everything put together.
Mm-hmm.
Today we are doing 400 flaps a year. So it's a big change.
Mm. And how did you move to breast? No, because I have seen that you're one of the top 10 breast reconstructive surgeons of, I think you're number 2 or number 1 in England. And I've seen many of those accolades. And you are also the first tutor or mentor of plastic surgery in the Royal College.
Yes. I mean, when I went there, I think that was that thing, they announced, advertised for a post called National Tutor for Plastic Surgery at the Royal College. So I just put in an application because there again, this is another thing. You are going into a new country, you need to prove yourself. So you are looking at every opportunity, and that's what Indians do when they go out. They want to do much better than the locals, and that's how I landed in that job. And going into breast surgery was again very it was very organic. It didn't sort of, I didn't plan it. I wanted to be a head and neck microsurgeon. In fact, I spent some time in Sloan Kettering Memorial. I spent 8 weeks with a gentleman called Jatin Shah. He's a very well-known surgeon. And I wanted to do head and neck. But when went back to UK, the unit, they didn't need a head and neck surgeon because the volume was small and there was another guy who was doing it. And so I wanted to do microsurgery. So if I can't do head and neck microsurgery, what else can I do? And that's how I went into breast.
How did you gravitate towards breast?
Breast was purely opportunistic. I suppose my desire for microsurgery, at that time I wanted to do head and neck, but head and neck, there was already somebody doing head and neck work. So as a consultant, I wouldn't get that stream of work. So the next avenue was breast surgery. So it was microsurgery which drove me into breast. Now in any unit in UK, 30 or 40% of the microsurgical work is breast related because that's a big volumes.
Is it the same in India? A microsurgery in breast is what extent?
I think if you take all the microsurgery that's going on in India, breast microsurgery might be 0.01% or
Why
something.
that?
I think that's because breast reconstruction itself is not very well established here. But even I'll go one step further. Breast oncology is not properly sort of delivered, or the structure of delivering breast oncology is very variable in India.
Actually, I had written in one of the write-ups recently saying that in India, breast is operated by everyone. All general surgical units do breast. And whether they follow any scientific protocol, we do not know, because for that matter here breast is done by general surgeons, breast is done by endocrine surgeons, breast is done by plastic surgeons, and breast malignancies. I don't know whether that is a right way to do it, because the so-called focus oncoplastic or breast onco surgeons are very, very limited.
That's a very valid thing, and as a person who works in a system in the West, certainly in UK, USA, France, Germany, breast has a massive presence in the surgical unit. Breast units, breast clinics, and they are all very process driven and a very systematic way of assessing breast pain, because 1 in 10 women get breast cancer. It is not to be sniffed at. And the nuances of treating breast cancer is not anymore just take the breast off and be happy. There is lots of things, nuances. You can preserve parts of the breast, you can, the hormone therapy, whether to do something to the opposite breast, whether risk reduction surgery for BRCA gene, what do you do with the node, sentinel node, which level do you clear? All these things are protocol based, and we know there are certain methods which will serve the patient better. So just one big hammer, take the breast and the axilla and send the patient home. And lymphedema. Now we don't see so much lymphedema because we don't do such drastic lymphatic surgery, which is not necessary for all types of tumors. So those nuances are the things, because I've had this discussion with some breast surgeons who are sort of general surgical oncologists. They have the attitude, yes, what's there in breast? it's a simple thing because they do very complicated colonic work or laparoscopic work, and then when it comes to this is like a light relief at the end of the list. But it's not so. For the lady, it is a massive thing. And of course, I don't think the survival is the only thing. It's also the quality of life, that side, the reconstructive side. So there are so much in breast that has to be explored in India. And I think this is maybe the next 10, 15 years we will see that happening, because we do see more surgical oncologists who are specializing in breast only. Coming up in every city, there are one or two.
And how commonly you find plastic surgeons, cosmetic surgeons specializing in breasts in India? Is there any group like that, or sizable group? Exclusive breast work?
There is not, but what has happened in India in the last maybe 7 or 8 years, there's a meeting which has happened called BRASCON, a Breast Reconstruction Awareness Congress, I think that's what it means. And Breast Reconstruction Aesthetic Surgery, Reconstructive and Aesthetic Surgery Congress. And this happens every year, and that has gained some momentum. So lots of plastic surgeons are going and attending to learn techniques of reconstruction of a breast post-cancer or partial breast reconstruction, cosmetic breast work. There's a bit of a momentum there. And then on the side by side there is this group called ABSICON, which is the Association of Breast Surgeons of India. That is also in its infancy, maybe about 4 or 5 years into its being. And that is attracting more people. These are the breast surgeons who go there and learn about oncoplastic techniques and of course oncology and oncoplastic techniques. So it is happening, but it has to go much faster.
No, one tricky question. Do you think the breast onco surgeons should also do plastic, or I mean, is that the way, or is it also that the breast plastic people do some onco surgery also?
You're talking to the right person, because I have a lot of the thing in this, because I was part of the first breast plastic interface group 20 years ago in UK, and we came together with breast surgeons because see, breast is a massive service delivery problem, because there are so many women with, if you say 1 in 10 women get breast cancer, or maybe another, you need to see for every cancer, you need to see another 10 women to rule out the cancer. So if you're looking at this workload and the knowledge you need to do to go through this, you need to have onco surgeons doing breast oncology. With regards to service delivery, there are many, there's a spectrum where onco and plastic come together. Or you can take away a small lump and suture the breast together, or you can take away a small lump and modify the breast into a better shape. That's oncoplastic techniques. Or you can take away the breast and place a small expander under the skin, and you can put an implant. And you can use latissimus muscle, and then you can do microsurgery. So the whole gamut of things. And in the British system, I am of the opinion that the oncoplastic work, as in removing the cancer and reshaping the breast, should be taught to the oncosurgeons, because it seems very redundant. You take one tumor and somebody comes and just moves the tissue. It is not. It's a very logical for the... Of course, if you have to go to the next step of reconstruction, like placing an expander implant, if that oncoplastic surgeon is that way inclined and they want to learn it, that will be a watershed area which both plastic surgeons and oncosurgeons can do. And then, of course, the microsurgical reconstruction, I do not think an oncosurgeon will be able to do, because you need to be entrenched in the micro world to be a good microvascular reconstructive surgeon. Here you need to be an oncosurgeon to produce. So there is a watershed, but there are roles for each one.
See, the present scenario in India, we see 70% of the medical students are girls. I don't know how was it during your time, maybe 30%.
Yes.
The percentage of girls joining medicine is increased. Not just that, but 50% of the general surgery postgraduates are girls actually. and they have difficulty in choosing what next. And it is quite interesting to know that breast surgery cannot not simply breast surgery. Oncoplastic is another huge area where there's a lot of scope for these young women surgeons. They should keep thinking on those lines because of the volume of patients which we have. Now, see, there are so many breast reconstruction surgeons, and there are so many breast microsurgeons, but how is it you are so special? What are the innovations that are credited to you? Or but I keep reading that you've done things which many others didn't in microsurgery. What are those which you stand apart?
I think different types of your career, you innovate and you try to do some new things and write papers and publish. So I've been quite prolific in publishing nuances of techniques or some new techniques in reconstruction. And one of the areas was using the thigh as a microsurgical transfer to reconstruct breast, which I've done quite a lot of work on. But more recently, my effort has been about slightly away from surgical techniques. It's about the process. So I've been process mapping the procedure, the microsurgical procedure, which is a long operation, multiple steps, and try to reduce the time taken and make it time efficient. So if you mention my name in our sort of peer group of thing, that's what they will be talking about, or they will associate me with first instance, because we do these operations very slickly. It used to, many places it might take maybe 6-7 hours to do one of these. We'll do it in 3 hours or 3.5 hours, not because we are working fast, but we work smart. We have process mapped, and there's a team. So that is my USP now. That's where I'm focusing my efforts.
And what is your role as a mentor or tutor in the Royal College? What is that you do?
It was. I've given it up maybe 10 years ago. There's somebody else doing it. It was to establish courses in plastic surgery. That's not only breast. Of course, I set up 3 courses in breast because that was my special interest, but hands and things, to bring faculty together, and you kind of establish courses. And there again, one of the problems, we were talking about other problems between two countries, differing problems. The trainees, they have what's called European Working Time Directive. So they spend very little time in the clinical work. So they need to have their competencies checked and tested. So they have to attend so many courses to have their certificates. So we need to give them courses on basic hand course, intermediate hand course. So those were the things I established.
Now, a couple of students, like there's the super specialty selection is over just about 2-3 days ago, and a couple of students have written to me saying that now we're going to a new place to do our specialty, plastic for instance, for 3 years. How should we work? How should we, what is that, how do we spend our 3 years usefully? Because it's not uniform all over. Different institutions have different protocols. Now, if you have to advise just a newbie in plastic surgery as to, now since you've seen hundreds of them, mentored so many, what will be your advice in a short
I think as with anything, foundation has to be right. You need to get your basics right. And plastic surgery is, in fact, it's a true general surgery. If you are a plastic surgeon, you operate on the scalp to the foot, different areas, different things. You don't go inside the abdomen, but otherwise you do everything else. So you have a vast area to cover with anatomy and the nuances of each area. So I would suggest that they get a good textbook. At the moment, the textbook that's going is called Nelligans. Okay. That is a multi-volume textbook, and of course you get it online and so on. And have a systematic way of going through everything at the same time, different topics, chapters, because depending on which unit you are, you may not get exposure to a particular specialty at all. So you have to be knowledgeable in all, and I think getting your factual information simultaneously, don't wait for the last bit of your last year to start reading up. From the beginning read. And also one other thing I do recommend people who are visit places. If you have 2 weeks vacation, you can take off and go and see somebody completely different, an area of interest. You might be working in a hand unit and you want to see some cleft lip and palate or something. You book a time with somebody, go and watch them, even for 2 days, 3 days. Watch an expert do that. Those things are very valuable, and they might change your whole course of how you're going to specialize and so on.
And if somebody wants to specialize or subspecialize in plastic, suppose they want to go abroad, do you think they should have some basic qualification in India to go there and fine-tune their...
100%. My thing would be, if somebody wants to do plastic surgery, some bit of their training abroad, get your degree here. And then you can apply through the Royal College of Surgeons. There's a program for the international surgical trainees. And there is a department at the Royal College of Surgeons of England, and there are very, very supportive people. They give you some kind of a sponsorship. You apply for a job in one of the units, and then you tell them this is the unit, there's a potential job. They get you 2 years of limited registration, and you can spend time doing a fellowship in a particular area of your thing. But if you were to come there and start plastic surgery training, you would waste a lot of time, because you'd have to do general surgery and a registrar in some surgical specialty, then try to apply for a job, then you lose traction.
Now, what have you given back to India?
Very little, I think. That is one of the things I do feel. I've been coming to the Indian plastic surgery meetings and talking about breast reconstruction and so on, and I do come and do courses and things. Of course, that I'm sure would have motivated 1 or 2 individuals, and we have had a steady stream of fellows we have had who have come and learned from us and gone back to India to practice. I think that's not enough. I hope to start something right earnest. It is quite a poignant time for me. I'm doing this interview. Next year I'm going to be here 1 week every month. That is my plan. Every month, 4th week of the month, and to really to push this breast reconstruction. And I've been battling with it, why it hasn't developed. I didn't know whether it's chicken or egg kind of situation, because good quality work is not provided, so people are not wanting it. So that kind of thing, I hope if we deliver it, if we did provide some good outcomes with reconstruction for some of the cancer patients, maybe that will snowball into a bigger sort of thing with time.
It was wonderful talking to you, and thank you so much for spending time, and we hope we'll catch up with you some other time whenever we visit India. Thank you.
Thank you very much. Thank you.